Hello and welcome to my Ophthal teacher. I'm starting the topic diabetic retinopathy from this lecture series onwards, and I intend to complete it in 3 to 4 lectures of 20 minutes each. And it is extremely important for all ophthalmologists in training or in service. So, this is not an all-inclusive presentation, but then I've tried to explain as much as possible in a limited amount of time. So what is diabetic retinopathy? Simply microvascular complication of diabetes affecting the retinal blood vessels, mainly capillaries, right? So it's a small blood vessel disease. Now, whenever we say when we talk of the ophthalmic manifestations of diabetes, the first thing that comes to mind is diabetic retinopathy because it is the most common manifestation. And we only think of diabetic retinopathy. But then there are several other manifestations of diabetes, the underlying pathogenic mechanism of which is neuropathy mostly and increased blood sugar levels. So these include iris transillumination defects, unstable refraction, recurrent stye, xanthelasma, accelerated senile cataract or faster progression of existing cataract, most of which is of the posterior subcapsular variety in nature, neovascular glaucoma, ocular motor nerve palsies, with the sixth nerve palsy being most commonly seen, reduced corneal sensitivity, papillopathy or involvement of the optic nerve head from diabetes, and pupillary light near dissociation or presence of accommodation reflex with loss of light reflex, the last two being very uncommon. So I would also like you to please go through the anatomy of retina beforehand, just a basic overview so that you understand in much better detail as to in what layer of the retina is that particular pathology present. So presuming you will go through the anatomy once, I'm going to talk about retinal circulation. So the normal retina has a functional inner blood-brain barrier with intact endothelial cells. Please excuse me for that brain. It is inner blood retinal barrier. Of course, structurally similar to the blood-brain barrier. So inner blood retinal barrier and outer blood retinal barrier with intact endothelial cells and pericytes. So uh, this is the outside, the from outside in. This is the deeper retina and this is the external or the outer retina. Okay, inner and outer retina. So the layer of choriocapillaries, Brooks membrane, retinal pigmentary epithelium. Then comes the layers of rods and cones, the outer plexiform, then the layer of bipolar cells, inner plexiform, ganglion cells, nerve fiber layer. I hope you can visualize these layers once you have read the anatomy. And the nerve fiber layer is and then followed by the internal limiting membrane, and it is the nerve fiber layer which makes up the bulk of the optic nerve, right? So the superficial plexus, the intermediate plexus, and the deep plexus are the inner retinal blood supply. Okay, and they are present in these corresponding layers, that is the nerve fiber layer, the inner plexiform layer and the outer plexiform layer. Okay, and it is these blood vessels that are mostly affected in diabetic retinopathy. Okay, superficial plexus, intermediate plexus, deep plexus, nerve fiber layer, inner nuclear layer, outer plexiform layer. These are the location of the various pathologies seen in diabetic retinopathy. Just an overview of the structure. So basically, this is the capillary, the structure of a capillary. Okay, these three plexi are actually the capillary plexus. So the structure of a capillary, this is the lumen, the endothelium, and between the individual endothelial cells are tight junctions. So it is these tight junctions between the retinal capillaries at these various layers that form the inner blood retinal barrier, and it is this inner blood retinal barrier that is primarily disturbed in cases of diabetic retinopathy and other vascular retinopathies. The outer blood retinal barrier, on the other hand, is made up of two things. This is your RPE, it has tight junctions. So, number one, the tight junctions between the adjacent RPE cells and the choriocapillaries along with the Brooks membrane complex. So, this forms the outer blood retinal barrier, primarily formed by the RPE tight junctions. So that's about your outer and inner blood retinal barrier. Today we are going to study about a disease that affects the inner blood retinal barrier. Pathogenesis. So, hyperglycemia, increased blood sugar levels, activates several pathways, several alternative pathways. So, normally, extra blood sugar is diverted into the pentose phosphate shunt pathway and is metabolized. Excessive sugar enters the polyol pathway, which we also know as the sorbitol pathway. Sorbitol is something that causes osmotic stress. There are some other pathways, that is protein kinase C activation, which starts its own cascade, oxidative stress, reactive oxygen species, and formation of advanced glycation end products, very, very important, and RAS or the renin-angiotensin system. So these are the pathways that are activated under conditions of increased blood sugar. And what does it primarily do? It affects the vascular endothelium. All these pathways, reactive oxygen species, and these polyols, they cause some sort of damage to the vascular endothelium by various mechanisms. For example, oxidative damage, osmotic damage, and so on. This in turn leads to increased vascular permeability, which in turn leads to diabetic macular edema. Vascular endothelial dysfunction also activates the well-known Virchow's triad and leads to blood flow dysfunction or stasis of blood. It also leads to retinal ischemia, because obviously if there's a problem with the endothelium, there is a problem with the blood vessels, there is decreased blood supply to the retina. Now decreased blood supply to the retina because of the endothelial dysfunction in turn leads to upregulation of these factors, these pro-inflammatory factors, which are known as HIF, VEGF, IGF, that is hypoxia-induced factor, vascular endothelial growth factor, which is the most widely studied and the biggest culprit of all the things happening in diabetic retinopathy, and insulin-like growth factor, and erythropoietin, of course. All these factors, especially the king of all of them is your VEGF, leads to retinal neovascularization, which is the hallmark for your proliferative diabetic retinopathy and its associated complications. So that was the pathogenesis at a biochemical or a cellular level. What happens after that? So dysfunction of the blood retinal barrier, right? All those things are causing endothelial dysfunction, which in turn is leading to the loss of blood retinal barrier, inner blood retinal barrier to be more specific. We saw what it was made up of. So this dysfunction is in the form of loss of pericytes. Now look at this blood retinal barrier, or in simpler terms, a retinal capillary. It has a lumen. It has endothelial cells which are sticking to each other by tight junctions. It has a basement membrane, the basement membrane of the endothelial cells, and it has these contractile muscles known as the pericytes. This is a normal retinal blood capillary. What happens in diabetes? You see, there is loss of these endothelial cells. There is increased thickness of basement membrane because of deposition of glycation end products, and there is loss of pericytes. So a weakened capillary wall is going to pouch out from here, leading to the formation of microaneurysms. It may leak out, leading to hemorrhages, exudates, and ultimately it will decrease the blood supply, leading to neovascularization. These are the pathological hallmarks. All of these you see on the right side are pathological hallmarks of diabetic retinopathy. So that is what is elaborated in this flowchart. Dysfunction of inner blood retinal barrier. This in turn starts a cycle of inflammation, damage, and cellular death, which in turn activates microglia and glial cells. These are the phagocytic cells present in neuronal tissue. These cells they release the pro-inflammatory cytokines. These cytokines again act on all nearby vasculature and neuronal cells, causing further damage, and the cycle propagates. So, when you are asked to write answers about the pathogenesis, etiopathogenesis of diabetic retinopathy, you can write it like this. This is just a student who has very beautifully, summarized all of these things in the form of flow charts. So, use a lot of colors, use arrows, okay? And see, this is how nicely you can summarize. So, she has written aldose reductase, accumulation of advanced glycation end products and free radical production. So this is the cellular level, okay, cellular damage, she's labeled it. This cellular damage comprises, so what does it result in? It results in endothelial cell loss, pericyte loss, and thickening of basement membrane. Pericyte loss is the first histopathologically evident change in cases of diabetes. Then what does hyperglycemia do? Hyperglycemia causes hematological and biochemical changes. What are these changes? Increased platelet adhesion, increased blood viscosity, the Virchow's triad, as I mentioned, leukostasis. So cellular damage in combination with this hematological and biochemical changes together leads to microangiopathy or blood retinal barrier dysfunction, usually affecting the precapillary arterioles, capillaries, and venules, which are collectively known as the smaller blood vessels. Here again, the same thing, breakdown of blood retinal barrier leads to edema, exudates, and hemorrhages, weakened cell wall, outpouching, leading to microaneurysms. So here she has explained the pathogenesis at the cellular level, and here she has explained the signs of diabetic retinopathy, that is edema, exudates, hemorrhage, microaneurysms, irma, neovascularization. So the underlying mechanism of the signs. And see, these are the pro-angiogenic factors. The number one is VEGF, PDGF, HGF, TGI. These are all of them are released by the retina, and there is anti-angiogenic factors such as these which are decreased. Okay, so they promote neovascularization. So this is how you should write your answers when somebody asks you about pathogenesis of diabetic retinopathy. Epidemiology. So, in throughout the lecture, I have just highlighted the landmark studies of diabetic retinopathy in green. I am not going to discuss these studies separately because it's going to take a lot of time. They are mostly of historical importance, even though they find application in today. That's why I'm saying they are all landmark trials. Okay, so you should know the full form of these studies and the basic conclusion from these studies, because these studies have framed the management of diabetic retinopathy that we know today. Okay, so prevalence of diabetic retinopathy is reported in several population-based studies, and it is highly variable. So one such study was Wisconsin epidemiological study of diabetic retinopathy, which stated that in young diabetics, the incidence of any retinopathy is 71%. Then in older diabetics on insulin, the incidence or the prevalence is 70%, and maculopathy is most prevalent in old diabetics on insulin. Old diabetics not on insulin, or rather type 2 diabetes, the incidence of retinopathy is 39%, whereas that of PDR and maculopathy is comparatively less. So the last one is type 2. The first two are probably type 1 diabetes. So coming on, that was about the etiopathogenesis. Okay, coming on to the risk factors for developing diabetic retinopathy. So we can broadly categorize as modifiable and non-modifiable. And the only modifiable risk factor, unfortunately, is a poor glycemic control. All of the others are non-modifiable risk factors. But this modifiable risk factor itself is the most important. Okay. So, number one, duration of diabetes. In fact, it is this the second factor which should be number one. It is this one that's the most important. So, poor glycemic control, intensive control of blood sugar prevents progression of diabetic retinopathy or development of diabetic retinopathy. There are two randomized clinical trials which are highlighting this particular risk factor. We will see in the subsequent slide. Duration of diabetes, most important, strong predictor of proliferative disease. Please remember the figure underlined 5% of type 2 diabetes patients have DR at the time of presentation. This is a rule of thumb. Development of DR after 10 years is 50%, after 30 years, 90% in young diabetics. Okay. So that is 2 points about duration of diabetes that you can remember, or at least remember this much, that it is a strong predictor of proliferative disease, and it is the most important factor among non-modifiable risk factors. Among modifiable risk factors comes poor glycemic control. So these are the two trials, the DCCT trial and the UK-PDS trial, both very, very important. Okay, I've just summarized these trials. Please remember the underlined part. DCCT, that is Diabetes Control and Complications trial, said that for every 10% reduction in HbA1c, there is a reduction in 35 to 40% risk of retinopathy progression. The conclusion is tight control of blood sugar delays the progression of DR. Then the UK-PDS study, what you should remember, intensive BP control leads to a 30%, 37% reduction in microvascular complications of diabetes in type 2 patients. This was type 1. And the outcome was the rate of retinopathy progression reduced and the need for laser also reduced in patients receiving intensive insulin therapy compared to conventional treatment, that is oral hypoglycemic agents. So again, two trials highlighted in green. Pregnancy, the third risk factor, may cause rapid progression of development of DR, especially if there was a greater pre-pregnancy severity of retinopathy, if there was a poor pre-pregnancy control of diabetes, if the diabetic control during pregnancy is exerted too rapidly, especially in the first trimester, and if there is coexisting preeclampsia. Diabetic macular edema happening during pregnancy usually resolves spontaneously and does not require any treatment. Hypertension, fourth risk factor, very common in patients with type 2 diabetes and should be rigorously controlled, as we saw previously in the UK-PDS study. So this kind of rigorous control will cause 37% reduction in microvascular complications of diabetes mellitus. Tight control, especially beneficial in type 2 patients, diabetes patients with maculopathy. Fifth risk factor, nephropathy. If severe nephropathy is there, it causes worsening of the diabetic retinopathy, and genetics. That these are some of the genes which are implicated in genetic risk factors, HLA-DR3, DR4, and SNP means single nucleotide polymorphisms in VEGF gene. So that's all about the risk factors. Now coming on to the signs, please understand these signs well, because they're going to help you further in the diagnostics, investigations, and of course, the treatment of diabetic retinopathy. So microaneurysms, these are the hallmark of NPDR or non-proliferative diabetic retinopathy. This is the size. So each and every point is important. Okay, that's why I'm saying it is not an all-inclusive presentation, but it has included all the essential points at least. So you see, this is a blood vessel wall, a capillary, small vessel. So there is a weakening, there is loss of pericytes, and there is an outpouching happening. And sometimes this outpouching pinches off from here and becomes a microaneurysm, right? So focal dilatation of the capillary wall happens wherever there are pericytes absent. So this happens, or sometimes fusion of two arms of a capillary loop can also happen. Inner capillary plexus in areas of capillary non-perfusion, this is where it is localized. Okay, so microaneurysms are seen in inner capillary plexus, which in turn is located in the ganglion cell layer, and it is situated in areas of capillary non-perfusion, in the areas of CNP areas, as they are known as, in the CNP areas of the retina. These aneurysms in turn may leak into the retina or they may thrombose. Okay, So leaking aneurysms are easy to identify. Thrombosed aneurysms are often confused with dot hemorrhages. So microaneurysms, earliest sign of DR, hallmark of NPDR, and how do they appear? They appear as tiny red dots, indistinguishable from dot hemorrhages. You see these dots? Now in a picture like this, you cannot make out whether they are aneurysms or dot hemorrhages. You can do so only if you do an angiography of the retina, which is known as fluorescein angiography. So that will show you differentiation between dot hemorrhages, which will cause a block fluorescence, they'll appear dark, and non-thrombosed microaneurysms, which will be filled with blood and they will appear white or hyperfluorescent. Okay, that is the principle. Retinal hemorrhages. The second sign. Now, we saw that there are plexus, the capillary plexus exist at 3 levels. So the hemorrhages will also exist at the corresponding 3 levels. Okay. So retinal nerve fiber layer hemorrhages arise from the larger superficial precapillary arterioles. Okay. These represent the nerve fiber layer hemorrhages. And since the nerve fiber layer, it's made up of nerve fibers arranged in a very compact manner. So they are flame shaped. So these are flame shaped hemorrhages. Okay, they are these, they look like flames. Why? Because they are arranged in a compact nerve fiber layer, right? They cannot spread too much. Then intraretinal hemorrhages arise from the venous end of the capillaries and are located in the compact middle layers of the retina, the middle intermediate capillary plexus, and they look like this. They look like dots and blots, okay, because they can spread from the center outwards because there is still some place to spread in the middle layers of the retina. That is the plexiform and the outer plexiform, mostly the outer plexiform and the inner nuclear layers. There is ample space for the blood to spread and it spreads in a circular fashion leading to dot and blot hemorrhages. Sometimes you may find deeper, dark, round hemorrhages such as these. Now these are darker because they represent hemorrhagic retinal infarcts that are located in the middle retinal layer. Okay, these are hemorrhagic infarcts. The blood has been there for a long time and it is located in the bilirubin, it has started to break down, plus the blood in this case is located in the deeper layers, hence the dark color. Okay. Coming on to hard exudates. Hard exudates, this is just a schematic showing the same. So you see, this is a hard exudate, it is basically located near the blood vessel, right? So why are they happening? They are because of chronic localized retinal edema. They develop at the junction of normal and edematous retina and they are present in the outer plexiform layer. You must know the level of the pathology okay? That's why I'm saying each and every point is important. They are composed of lipoprotein and lipid-filled macrophages. Okay, located mainly within the outer plexiform layer. They are waxy yellow lesions with distinct margins. Okay, very sharp waxy yellow lesions. They are arranged in clumps or rings at the posterior pole. So you can see this one is like a ring, and you see they are scattered. Yellow, white, waxy yellow lesions with sharply defined margins or distinct margins, which differentiates them from drusen. Okay, drusen are seen in age-related macular degeneration, the dry variety of ARMD. You see here they have accumulated and they have formed a sort of a plaque which carries very, very poor prognosis. Okay. Um, Often these hard exudates occur near leaking microaneurysms because they are made up of lipids, lipoproteins, and macrophages which may have leaked out from some blood vessel only, no? So they are often found near these leaky blood vessels, okay? And this histological picture is basically showing you, eosinophilic deposits in the outer plexiform layer, right? So that's just the histological section of the retina. And you see here, these are some dot blot hemorrhages also, okay, nearby. Macular edema. So macular edema is the most common cause of visual impairment in diabetics, especially type 2 diabetes. So in the previous slide, you saw an incomplete ring. This one is a complete ring, and this is what is known as succinate retinopathy. So what is edema composed of? Either There will be fluid, which will cause elevation of the retina. And along with fluid, there will be what? There will be leakage of lipoproteins, macrophages, which will be in the form of hard exudates, or there may be leakage of blood, which may be in the form of hemorrhages. So macular edema means, when we say macular edema, we are talking both of retinal thickening and hard exudates at the macula. So it can be diffuse or focal. If diffuse, it will be caused by extensive capillary leakage. If focal, it is caused by focal leakage from microaneurysms. Okay, so you see at the center there are these groups of microaneurysms, and the whole circle of hard exudates surround them. This is an angiography of the retina. The same picture, when the fluorescent dye is injected, you see that these vessels are leaking out. Okay, then this one. So fluid is initially located between the outer plexiform and the inner nuclear layers. Focal maculopathy, I told you, well circumscribed retinal thickening with complete or incomplete ring of exudates. Diffuse will be like a diffuse sort of picture. Diffuse retinal thickening with scattered microaneurysms and small hemorrhages. The same picture will be scattered all over. And ischemic maculopathy, very, very important. Now, sometimes in ischemic maculopathy, the macula may look absolutely normal despite reduced visual acuity, and you would wonder why. Because you do not see any hemorrhages or vascular changes or, any hard exudates anywhere. Unlike this picture, very much unlike this picture. This picture, obviously, you can see a lot of changes, even though you don't see any edema or hard exudate in the area lying within the circle. But then when you do an FFA of the same thing, see, you see this dark area. This dark area is where no blood vessel reaches. And this is what is known as ischemic maculopathy. Okay, there is complete ischemia. Dark areas mean ischemia. So ischemia of the macula. All right, ischemic maculopathy. Cotton wool spots. Cotton wool spots are accumulation of neuronal debris in the nerve fiber layer because of ischemic disruption of axons. So axons obviously have their own blood supply. When this blood supply is affected, inflammation happens and these axons become swollen with intracytoplasmic bodies, which are known as cytoid bodies. And this over here these are these globular aggregates. They are known as cytoid bodies, and they are present in the nerve fiber layer. Okay, this is the light microscopy picture. This is just a schematic. And what do they actually look like in the retina? They look like small, fluffy, whitish, superficial lesions that obscure underlying blood vessels, best seen in post-equatorial retina, that is the posterior pole. Why? Because the nerve fiber layer is the thickest in the posterior pole, and since the pathology lies in the nerve fiber layer, it is very well seen in the posterior pole, right? So that's your cotton wool spots, also known as soft exudates, which is a misnomer. They are not exudates, they are ischemic infarcts. Venous changes constitute, basically they are seen in as the severity of the NPDR increases. So there can be generalized dilatation and tortuosity, looping, beading. See, this is a loop, right? These are little beads. You see these beading structure, and sometimes the beading, there will be alternate dilatation and constriction looking like a sausage. So venous changes correlate with likelihood of developing proliferative disease. Coming on to IRMA, intraretinal microvascular abnormalities. What are these? These are arteriolar venular shunts which travel from arterioles to venules. This one, okay, between arterioles and venules. See, this one's an arteriole, and this thicker one is a venule. Again, this one's an arteriole. So these are traveling between the two. This is the arteriole, the thinner one, and the whiter one. And this is the venule, and this is your IRMA. Practically speaking, very difficult to differentiate from neovascularization, as you can see in the second picture. So how to differentiate? The differentiation is only on the basis of fluorescein angiography. Okay. So what will you see in IRMA? IRMA will be non-leaky, whereas neovascularization, which consists of new vessels which are fragile, will be leaky. Okay. Both of them would appear hyperfluorescent, but IRMA would not leak. The fluorescence will not increase, whereas it will increase with time in cases of neovascularization. As far as the appearance is concerned, both of them look like fine blood vessels and therefore clinically difficult to distinguish. Neovascularization is the hallmark of proliferative disease. Pre-retinal new vessels are most commonly seen at the posterior pole. So you see, this is the NVD or the neovascularization at the disc, right? You see these fine blood vessels, very fine blood vessels. These are fragile blood vessels, okay? And they are VEGF induced. See, these are this is NVD, okay, new vessels at the disc, neovascularization on or within 1 disc diameter of the optic nerve head. See how they are leaking in angiography? It is the same picture. It's an angiogram of the same area. So you're seeing leakage. Okay, you'll understand it better when you see a live angiogram being performed. With time, this whiteness would increase, suggestive of leakage. Then this is neovascularization elsewhere, NVE. Okay, you see these are fine vessels which assume a frond-like configuration. So that's your NVE. And sometimes this NVE develops tractional fibrotic bands like this, which appear whitish. Also, you can have new vessels on the iris or rubeosus iridis or NVI, which carries a high likelihood of progression to neovascular glaucoma. So just like on the disc and on elsewhere on the retina, you can also have new blood vessels on the iris. That is wherever there are superficial blood vessels. So you can also have NVI, right? So that's just your frond-like NVE. So those are my references. And in the subsequent lecture, I would try to discuss and complete the classification and non-proliferative diabetic retinopathy and probably macular edema. Okay, and subsequently we'll be talking about proliferative diabetic retinopathy. So thank you for listening and please keep revising.